looking at a subject related to tuberculosis, and very interesting subject that we'll be looking at today. But before I actually introduce the subject, I just want to do a quick audio test. Are you able to hear me and hear me clearly?
Yes, able to hear you.
Thank you so much, Aubrey. Yeah, so today we're going to be looking at drug-resistant TB, and in particular, we are going to be doing shorter treatment regimen for drug-resistant TB, which is the BPaLM regimen. And right, I was saying our subject matter expert for today is Dr. Muhammad Mputu, who's going to take us through the presentation. Later on, we will have an interaction on this subject, and I will introduce the other experts that we will be with to discuss this topic. So in the interest of time, allow me to invite Dr. Mputu to share his slides and quickly get into the presentation, and he can tell us his role in the program in his preamble. Thank you so much. So while we are at it, just a reminder on the echo etiquette, please keep all your microphones muted unless you've been invited to ask a question or a comment while the presentation is going on. To avoid distracting the presenter, please post your questions in the chat box and we'll be sure to address them there in the chat box, or maybe even ask you to say a little bit more about your question at a later stage when we get to the discussion. Dr. Mputu, over to you.
Thanks, David. Good afternoon, network. Some of you have already met me. Those who have not met me before, my name is Muhammad Mputu. I'm a physician as well as a DIRA TB advisor with the National TB and Epilepsy Program. Essentially, that's my main role. I provide guidance on technical issues to do with the TB in general, particularly patient care, clinical management of patients, and how to improve generally the TB program where patient care is involved. Some of you have probably met some of you in person in facilities. Last week I was on the Copper Belt. I don't know how many of you have met on the Copper Belt. So this afternoon, we are going to do a presentation. I think I did this similar presentation last year, but repetition is also a good way of learning. So if you were here last year, please don't get bored. Just it's like revision when you're in school, when you're revising things. So see this as a revision. So we'll talk about the shorter treatment regimens, options in the country, and then after that, interaction and see. So I will begin by outlining the two main objectives to outline the current DRTB treatment approaches we have, and then describe the shorter treatment regimen, especially with the issues to do with the implementation of it. Just to start off, as a reminder, we have three main groups of second-line drugs. That's Group A, Group B, Group C drugs. Group A drugs are currently regarded as the most important drugs, as levofloxacin, bedaquiline, and isolate, and then followed by Group B drugs, and then Group C drugs follow. If you pay attention to Group C drug, you'll see some of those drugs highlighted in green: ethambutol, delamanid, pyrazinamide, and ecuramide still play a critical role in construction of the current regimen that we have, although they've been placed in Group C. So this is a graphical way of showing what I was trying to say, that the important drugs are Group A. So if you see the preference is lean towards Group A. If you look at on a scale, the Group C are the most least preferred drugs. So I'll go back here. You can see in this group you have a lot of injectable drugs like BPaLM, amikacin, streptomycin, meropenem. These are not drugs that most of you even think about using, which is a good thing. I can't complain. But these are drugs that you need to be aware. At the moment, we only apply them when we have really no another option, like a salvage therapy, similar to what you do with HIV patients. So in terms of what the regimen constitutes for especially the longer treatment regimen, we have the core drugs that come from group A, and then we've got additional drugs that come from B, and then for group C, these are rarely required, but I will give a special situation when these are required to be used in group C. So for a shorter regimen, you just need to group all the drugs in group A and 1 or 2 drugs in group B, and you have your you have the longer treatment regimen. So we have essentially 2 regimens. So this is just for simplicity, but essentially we have 2 types of regimen. You've got the shorter treatment regimen and you've got the longer treatment regimen. The longer treatment regimen can be standardized or individualized. When we talk about a standardized regimen, what we mean is that every patient that is put on that regimen will be given the similar drugs regardless of who they are. So it's standard. So if you have 10 patients and you put them on a standard regimen, that means that all the 10 patients will be receiving the same drug. That's what a standardized regimen means. Individualized treatment regimen means that you have DST results, and the DST results have guided you to which drugs the patient is sensitive to, and so you design your regimen based on those DST results. Then the patient in that case has individualized treatment regimen. So we've been using these regimens, the overall regimen, the shorter and longer treatment regimen for some years. I think we introduced this in 2018, and some of the things that have been observed that had been consistent over these different types of regimen have to do with the choice of regimen by most clinicians. You will see that 80% of our patients tend to be put on the longer treatment regimens. Makes the shorter regimen not popular among clinicians. And then we've observed patients being put on treatment for the longer duration than they are needed. Remember that the shorter treatment regimen is usually up to 18 to 20 months, but we see patients being put on treatment for more than 20 months. Some of them have met patients who have been treatment for 24 months or longer. And then we also see patients complain of adverse drug reactions that are not being reported. So patients are coming to facilities with the adverse drug reaction, and no one is reporting those drug side effects. And then there's also issues to do with treatment fatigue and non-adherence using the longer treatment regimen. So what treatment fatigue means is that most patients are put on treatment for a longer period of time, then they get tired of taking your drugs. And then when they get tired of taking drugs, they become non-adherent. So it's a recipe for non-adherence. So patients will tend to stop your treatment, and some of them even stop coming to your facilities, and you lose them. You declare them lost of follow-up. It's not that they are dead or anything, because they're avoiding your drugs, so they don't want to come to your facility and continue taking your drugs. For shorter treatment regimen, like I said, is not popular, and this is because some clinicians were reporting that they were seeing a lot of treatment failures among patients with shorter treatment regimen, but this is anecdotal. And then there's also issues to do with the pill burden. When we talk about the 9-month treatment regimen, these are some of the reasons that are commonly cited why clinicians prefer the longer treatment regimen. Then generally for all regimen, there's non-adherence to guidelines. So patients are still clinicians are not still following the guidelines that we have. They're not adhering to guidelines. There's also delay in making interventions. So for example, you have a patient who's been put on a longer treatment regimen for 18 months, and you are seeing the patient, you are in month 10 or month 12 of the patient, and your culture is still positive, and you are still giving the same, you have not acted to say this patient is not responding after 12 months of treatment, but you continue giving the patient the same treatment. This is what we mean by there's no intervention, or the intervention is delayed. Okay. And then there's also poor documentations of the actual regimen. So when you look through files or through the YATU database, it's difficult to tell which regimen the patient is on because the drugs are not clearly indicated. So it becomes difficult. So we have a lot of patients at the end of the year when we evaluate to see how many people received which drugs. We have a number of patients you can't tell which regimen they were in. Yesterday I was looking at the patient data, for example, for the half of last year. Out of 200, about 200, out of over 230 patients, 26 patients, you cannot define what regimen they are on. We know that at the facility, you know which regimen they are, but the recording, that is the problem. No one is recording these regimens clearly. So in this, so when we are looking at this regimen distribution, we can't tell what regimen the 26 patients are on. So we have the 9-month shorter treatment regimen. This is a regimen that we rolled out last year. No, actually, that's the year before in 2022 October. That's when we rolled out this treatment regimen. Up to date, there's been a very few patients that have been prescribed this regimen. Again, some of the reasons I've already indicated why, what reasons we are receiving, and we are asking why patients are not being prescribed this shorter treatment regimen. Common reason is that the regimen has a lot of bad pills. Another reason that we started receiving from some facilities that the facilities don't have the single dose, the ethambutol and pyrazinamide, so they don't know what to do. So the regimen is given over a period of 9 months with a provision to extend to up to 11 months. And the drugs, the group A drugs, that's bedaquiline, levofloxacin, plus a group B drug, that's in terms of clofazimine. Another group A drug that's there is linezolid. And then we have the group C drugs, that's the ones that are indicated in green. And this is where their role is important, where we can add this regimen, you can add these drugs to the ethambutol, pyrazinamide, and isoniazid to the regimen to form the 9-month regimen. So this regimen is given initially for 4 to 6 months. Then the continuation phase continues for 5 months. So the continuation phase is fixed. You can't extend the continuation phase to 6 months. It's fixed to 5 months. What you can adjust is the initial phase. So initial phase is given preferably for 4 months. But if there's no response to treatment for the first 4 months, you can extend to 6 months. This is how it works. An alternative form of this regimen is a regimen that will involve replacing you replace ethionamide, you replace linezolid with ethionamide. So this is an alternative form, but this is not the preferred form because ethionamide has more side effects than linezolid. So unless the patient you have reason not to use linezolid, so in the place of linezolid, you are going to opt for ethionamide. So this is the main difference between these two regimens. So also you have to take note that when you are giving the first option of linezolid is only given for 2 months. So at the end of the 2 months, you have to drop off linezolid. So this is the issues to do with the 9-month regimen. Maybe these maneuvers are what scares people to use it, but there's always help. There are always people who are aware how to use this regimen. You always reach out and you'll be guided how to use this regimen. Then the longer regimens, like I said, essentially you give all the group A drugs and either one or both group B drugs. And then I indicated that for individualized regimens, these are based on a phenotypic DST, where you have phenotypic results, and then you give the patient based on the phenotypic. So most of these patients are usually the patients that have either pre-XDR or XDR that will be given individualized regimens. But of course, there will be situations where some individualized regimen can be prescribed because of contraindications in certain individuals. For example, they've got allergy to a particular drug, and you can't use that because they can't tolerate a drug. You may want to design a drug that is safe for them, and then they have been put on an individualized treatment regimen. So using these regimens that I'm talking about, the focus here is the shorter treatment regimen. Is that now, as of today, WHO is actually recommending use of the 9-month treatment regimen in children, because now we can even give bedaquiline in children with all ages. The only exception is children that are classified to having extensive disease. This will be as described in the guidelines. So you can't use, when you think the child has extensive disease, you can't use the shorter treatment regimen. But luckily, the majority of children you're going to find with drug-resistant TB actually do qualify for a 9-month treatment regimen. The other option, again, of using this 9-month treatment regimen is in pregnant women and those who are breastfeeding. But here, you are not going to use a furamide because it's not allowed to use it in this group of individuals. So you use the 9-month treatment regimen, and then that's what is being now advocated for in pregnant women and those who are breastfeeding. Just remove furamide. Then last time we did speak about the 6-month regimen. Those of you who may not have heard of it, there's a 6-month regimen that there's been some logistical delays while we have not started rolling it out. The world is right now moving towards the shorter treatment regimen across, and there's even been a campaign that is called 1x4x6x24. So the first one is related to TPT. This is one represents a weekly dose of TPT that we have already started rolling out in some areas in the country. And the 4 months, the 4 here talks about the 4-month treatment regimen for susceptible TB, and then the 6-month treatment regimen. The 6 months indicates the 6 month of DRTB regimen, and the 24 indicates that by the end of 24, all the countries should have moved to these 3 forms of regimen. That means that even in Zambia, we want by the end of this year, or we've transitioned everyone on the shortest possible treatment available, so that we do away with the longer treatment regimens. So for most clinicians, they believe DRTB is very difficult to treat. Essentially, it's not very difficult to treat actually. But unfortunately, most of the patients are put on longer treatment durations. Most patients are treated for more than 18 months. This exposes them to drugs that are toxic for a longer time. So there's an exposure to toxic drugs for a longer period of time, and then the patients experience a lot of ADRs, or adverse drug reactions, that may lead to stoppage of drugs and potential amplification of drug resistance. In terms of outcome, we still see treatment failures, and even relapses with the longer treatment regimens. So what people are reporting that it's only seen in shorter treatment regimens actually not true. Potentially, we also see pre-XDR, potential for pre-XDR using this longer treatment regimen. So for the pre-XDR cases and XDR cases, unfortunately, they tend to be treated for an extended duration with individualized regimen. And then this also makes them have a lot of side effects. And then the patient becomes very fatigued. Those of you who've ever seen a patient who is being treated for pre-XDR or XDR, if there's someone here from Mazabuka, you may be aware of a patient who's at Mazabuka. She has been on treatment for a very long time. There's also a patient at UTH who comes at UTH, also has been on treatment for a long time. There's also another patient who's going to be on treatment for a long time in an intolerance. So we do have these patients, and you need to start looking out for them. So, like I was saying, the world is moving towards a shorter treatment regimen. There's a lot of drugs in development, and most of these drugs are directed towards TB in general. So one of these days, we will not be able to treat TB based on whether someone has susceptible TB or drug-resistant TB, but we'll be treating TB regardless of the sensitivity pattern. And this is because most of these drugs that have got a lot of numbers are new drugs. You can see a lot of drugs like TPAJ587 or SPR720. These are drugs that do not have names, but they will eventually be given names, and the efficacy will be tested, and in soon enough we'll be able to treat patients for a very, very short period of time. Then, so this is a similar information I was talking about. So we have a 6-month regimen that has excited the TB world. This came as a recommendation after a number of studies were done. The initial one was called the NIC study that looked at a 3-drug regimen for 26 weeks in form of bedaquiline, pretormanide, and lanezolide. And these patients who were being treated were those patients with XDR TB, or those patients who were described as having non-responsive or treatment intolerant MDR TB cases. So you will notice that the numbers are usually small when you are dealing with drug-resistant TB. The people who are enrolled in studies to evaluate these drugs tend to be low. Like this, in this study, there were like 109 patients. What would be good to have is a study that has, for example, 2,000 patients. That is a very powerful study for assessing this treatment regimen. But for drug-resistant TB, because of the small numbers, it's not possible. So for now, most studies will have these small numbers. Anyway, like you can see, with this 3-drug regimen, they looked at clinical resolution at 6 months after therapy. And 89% of patients who had XDR TB had recovered by 6 months of treatment, and 92% of those patients who had the MDR TB had recovered by 6 months. The only concern that was being noticed was that lanezolide seems to be the drug that had issues with the side effects in terms of peripheral neuropathy, which was reported in 81% of patients, and myelosuppression, which was reported in 48% of patients. Even now, we see most of our patients have one of these 2 side effects. If you start paying attention, you'll notice that your patients complain about peripheral neuropathy, or when you do a full blood count, you see their HB or their platelets dropping. So this is because of myelosuppression. Then another study that was done is a TB practical trial. This is another that study that was done in 2 stages that looked at the number in this study was a bit higher. There were about 552 patients that looked at the similar drugs, bedaquiline, pretormanide, and lanezolide. But in this time, there was moxifloxacin that was added, and there's also another drug, clofazimine, that was added. So they had 3 arms. They had 3 regimens that you were testing for 6 months. That's the BPaLM with the moxifloxacin, and the BPAC with the clofazimine, and the BPaLM regimen without the moxifloxacin or clofazimine. So this TB practical study is actually one of the main game changers for the DRTB treatment. And as soon as the results were released, experts were called to sit down, and immediately WHO adopted the findings from this study, and the recommendations were, it was recommended we start using this BPaLM regimen and the BPaLM regimen because it was more effective and safer than the WHO standard of care. And it was also the other one, also the BPaLM, was also proven to be effective and safe for patient. So again, it's a myth that having a longer treatment regimen is better than a shorter treatment regimen, because studies have actually shown that the 6-month treatment regimen was actually more effective than the WHO standard of care. So in this study, what they called the WHO standard of care was the regimen that we are currently using in the country, like the 9-month regimen and the 18-month treatment regimen. So another similar study that was also done was also called the next study. And again, using the next study, in this study, they compared injectables regimen that contained injectable regimens, and also compared the 6-month regimens of levofloxacin, bedaquiline, and lansoprazole for MDR-TB, and then they found that it was associated with significant improvement at 24 months compared to the injectable ones. Although, again, drug toxicity were also a concern of these drugs, but this has to do with the lansoprazole. So, based on some of this information, and some studies are still ongoing, WHO then adopted those regimens and then made a recommendation to countries, NTPs, to adopt this regimen for their patients. So now we have rather 3 short treatment regimens. The ones in green will probably be the ones we'll be using mostly, especially the second one. That's where the BPaLM with an M at the end will be the one that will be the main regimen for majority of our patients. This is given in patients who will be given for six months with a provision of extending to 9 months by WHO. For BPaLM, we are going to be using moxifloxacin. For those who have XDR or pre-XDR, or those who have evidence of fluoroquinone resistance, we'll be dropping off the moxifloxacin and just giving them BPaLM without the moxifloxacin. Alternatively, you can give them clofazimine if you want to give them a 4-drug regimen. But I don't expect that this one will be a very popular regimen. 3 drugs will be adequate to treat pre-XDR. Who will qualify for pre-XDR? For who will be qualifying for this regimen, the BPaLM regimen? So essentially, everyone, all adults, by definition, that's anyone above 15 and above will qualify. And then those who have pulmonary TB, and then those who have all forms of extrapulmonary TB, except those who will be having CNS, osteoarticular or Maillard TB. Those will not qualify. And then anyone, any patient, regardless of HIV status, will qualify. And among those who have received any of the drugs, but have received these drugs for less than 4 months, they also be able to qualify. That means that when you start doing the transitions, when your patient has taken treatment for 1 month, you probably would want to transition them to the shorter treatment regimen as well. So in those who will not be eligible ones are those who will be pregnant and breastfeeding ones, and then children. That's those who are below 14 years. Again, this is not because we can't give this drug. This is because we don't have information on the side effects of these drugs, especially predominant. Let me just be more specific, a bit more specific. The drug we are not sure about its effects in this age group is predominant. We know that bedaquiline, for example, can be given in children at all age group now. We know that, but we don't know the predominant. There's no information about the effect of predominant in children. We don't know the effect of predominant in pregnant and breastfeeding women. So this is why, for now, they're not eligible. But maybe with more information, they will be eligible in the near future. Also, if a patient is allergic to any of the drugs, the regimen, you can't give the regimen. So the regimen is rigid. There's no negotiating. So if a patient cannot give bedaquiline, cannot receive bedaquiline, it means that you are disqualified them from that regimen. They have to give them the 9-month regimen. Okay, that's what it means. So XDR patients again will be excluded. So this will need individualized treatment regimen. So so most of you may be familiar with the use of bedaquiline, but so I'll just pay attention to predominant. These other drugs are already in the country, so most of people are familiar with them. Just to mention, predominant here is a 200 milligram tablet that will be given once daily for 6 months. There's no dose modification for predominant. And then for linezolid, in those studies that were reporting very high levels of toxicities, is because they were using a higher dose of drugs. So they were using 121.2 grams milligrams daily. That's why they were reporting a lot of myelosuppression and peripheral neuropathy. So the subsequently in the TB practical, what they did in the TB practical study is that they reduced the dose. They were testing the lower dose of linezolid. So they were testing different doses of linezolid, and then they found that the 600 milligrams was as efficacious as the 1.2 grams. So there's no need for you to give 1.2 grams when 600 milligrams will do the same job. So this will be the dosing schedule for these patients. So because we are dealing with the new combination of drugs, and also because we have got concern about fluoroquinone resistance, and fluoroquinone resistance, mostly you come to know about it even 2 months after treatment initiation. So to cut for that, we're introducing XDR cartridges. These cartridges are already in the country, and I think some labs have already been set up to start using these XDR cartridges. So for you clinicians, you'll not be asking for testing with XDR cartridges. So you'll be asking for gene expert testing. What will happen is in the lab, when the MTB is detected and RR is detected, it will be effectively tested with the XDR. So XDR does not only exclude fluoroquinone, does not just check for fluoroquinone resistance, but it will also be checking for INH monoresistance. So some of the MTB detected are not detected, maybe INH monoresistant. So XDR will be able to give you quick results now. So you don't have to wait for DST from phenotypic DST to come from a reference lab. You can get these results from your local lab in the shortest possible time. So this will hopefully this will make clinical decisions easier because you have results available. So once fluoroquinone resistance is detected, the patient will have to be given BPaLM. If fluoroquinone resistance is not detected, then the patient will be given BPaLM. If it's just INH detected, you're going to treat the patient with the first-line drugs with addition of levofloxacin. So that's a different treatment regimen for INH monoresistance. So the initial plan was to start rolling out these drugs. We were supposed to roll them out last year, but things didn't work out as we intended. But now we can safely say that we have a batch of predominant that is now in the country, and we're just doing some logistics in between now and June to ensure that once we roll out this, we roll out in the most effective way. For example, we need to do some training and mentorship again. This is part of the mentorship and training as well, but we also need to do more training and mentorship. This will be site-based site visits. We need to train people from within provinces, and then after that, we start rolling out. Hopefully, in May or June, somewhere there. So after June, we expect that the transition process will start, but it may not start everywhere because the number of drugs will limit where we're going to start from. So if the next batch of drugs comes, we'll probably now go full throttle countrywide. So if you don't see this in your at your facility, it's not that we don't want your facility to treat patients using this regimen, but because we are limited to the drug supply. So we are expecting more drugs later this year. Once these drugs, once more supply comes in, then we are going to go full throttle countrywide. So you have to be patient with your patients so that the drugs come in, and then we start rolling out. Hopefully by 2025, we'll not be talking about the longer treatment regimen. All of us will be talking about the shorter treatment regimen. I'll end here. Thank you. Over to you, David.
All right, thank you. Thank you so much, Dr. Mputu. Very enlightening conversation on the shorter treatment regimen. I could see that there was a lot of activity in the chat box, and one of our subject matter experts, Dr. Chimzizi, was responding to some of those questions. Maybe before we get to those that are in the chat box, there's a hand from Moses Chisha from Ukwimi B Rural Health Center. Please go ahead with your comment or contribution.
Thank you very much for that privilege, Doc. I have a question, Doc, over a current patient who is on TB treatment. This patient was diagnosed with TB from St. Francis in 2021 December, and the patient completed his treatment. So in 2023, the patient came in again with the same complaint, and we tested the patient. He came out TB positive in 2023, 5 February. The patient started treatment again. So in December 2023 as well, we tested the patient for TB. The patient came out TB positive using GeneXpert. So fortunate party, RR rifampicin resistant, it wasn't detected. So now my question is, in this case, the patient in 3 occasions has been coming out with TB positive. What can we do? Can it be TB resistance? There's any drug resistance, or maybe it could be the problem with the machine, or maybe there's something wrong with this patient, because we have been found TB in him for 3 occasions. So I don't know what could be the advice to the room, from the room. Thank you.
All right, thank you so much. So before you go, just confirm for us the tests that were used. Was each instance, the test, was it being done by GeneXpert, or maybe a different test modality was being used? Because I think you only alluded to the last test having been GeneXpert positive. What about the previous 2 tests? And then I'll ask one of our experts on the call, Dr. Matigula, to respond to that question.
Okay, thank you very much. The first test, it was the GeneXpert from St. Francis Mission Hospital, and the results were high. And then the second testing, we did it from our local facility using BPaLM, and then we sent sputum for GeneXpert, which came out reactive. This was on the 5th February 2023. The first test was the 4th April 2022. Yeah, sure. And then the last one.
Yeah. All right. I think we've gotten the clarity. Maybe Dr. Matigula, maybe you could quickly respond to that question.
Hello, hi, David. Hello?
I'm all right, Doc.
All right, great. Sorry, I was multitasking. So I didn't get the years quite. You said.
So this is a patient that has been that was initially diagnosed with TB some years back, probably 2021. I missed the year, but every subsequent year when a test was done, it was positive, and the test that was being used was GeneXpert, and none of those tests was actually rifampicin resistant. So the question was, why are they having a positive test each time? Are we dealing with a case of drug-resistant TB other than rifampicin?
All right, yeah. So thank you for that. So I think I got it wrong. At first, I thought they were actually following up the patient and doing GeneXpert for follow-up. So first of all, to clarify, when the diagnosis is made using GeneXpert, that's just for diagnosis. But as you follow up the patient, you're not going to be using GeneXpert for follow-up because you may be getting a positive result. So it's important to look at the clinical presentation of the patient as well. Then again, even after treating TB, let's say you treat TB for a period of 6 months now, and then maybe just after completing TB, you try to do a GeneXpert again if it's within 5 years, 2 years or so, you can still get a positive GeneXpert, especially when you get results like it says stress and the like. So I would like to get more on the clinical context of the patient. Is the patient still symptomatic? Are they worsening? Or is just the case that is being interpreted in this case? Because it's possible to have a positive GeneXpert with a trace in a patient you're just from treating.
Okay, thank you very much, Doc. The patient is still positive to the signs and symptoms, muscle wasting, difficulties in breathing, cough, and chest tightness. Is still positive to signs and symptoms of TB. Thank you.
All right. Okay. Thank you for that. So if the clinical picture is such that they are still worsening, yes, it's possible you might be dealing with drug-resistant TB to other drugs, but it's also important to fully evaluate the patient for possibilities of TB sequelae. Sometimes we have patients who have post-TB lung disease. So because they've had TB before, there is that lung damage that has happened, and then they may be having repeated infections with some other drugs or with some other bugs, or they may have what we call post-TB lung disease from us. Because post-TB lung disease it describes a variety of a group of conditions that may affect the airways, that may affect the lung parenchyma. So we may have conditions like post-TB obstructive lung disease. Okay, so that would have to be evaluated. You may just have conditions affecting the parenchyma, like bronchiectasis, for example. So you need that full evaluation, but you can still request for other tests because the patient has been treated for TB before. So you can evaluate for resistance to other first-line drugs other than rifampicin. Yeah, but a full clinical evaluation would actually help in this case.
All right. Thank you so much, Dr. Matibula. Very good question that came in earlier regarding repeatedly positive expert. Key things I've picked up from the response possibilities are, yes, it could be drug-resistant TB with resistance to other drugs besides rifampicin. So a full DST would be indicated in such a patient. But of course, looking at the symptoms that have been given, this could be post-TB lung disease or post-TB lung disease or post-TB disability, as we are calling it in newer terminology. Let me get to the questions that are in the chat box. I know Dr. Chimzizi, Dr. Mputu have responded to this, but for the benefit of those that may not have seen, one question came in from Irene Walia. This should be Dr. Walia from National Health Council. She asked, is Pitomamid available in our country? And the answer was yes, it is available in our country. And Dr. Mputu also alluded to that in his presentation. Then there was a question from Silvana who asked, can we replace bedaquiline with delamanid in an event of shortages of stock for bedaquiline? Maybe let me invite Dr. Chimzizi to speak to this. I know you put a response, but maybe you could just vocalize the response. Dr. Chimzizi. Okay, Dr. Chimzizi, I'm not sure if he's still on the call. Maybe Dr. Chanda, Dr. Chital Chanda, you could respond to that question. on replacing bedaquiline with delamanid in an event of BDQ shortage?
I'm with Dr. Mwanga here. We're unable to unmute, so we have now able to speak.
All right,
If Dr.
thanks,
Chada
Dr.
is there,
Chimzizi.
Okay, I think the simple answer is the same that we said yes. You can replace with bedaquiline with delamanid. I think what is most important is also to make sure that because maybe it's because the stock out of bedaquiline, what is more critical is also to look at what time, at what stage is this stock out, because maybe the patient may be completing, or maybe it's at the beginning of the treatment, but entirely there is not much to worry about. It's very is a drug that we can use when we have a stock out of bedaquiline. I still remember Dr. Mputu also presented the same during the situation room. Maybe Dr. Mputu, you can expand based on what you also you delivered in the situation room.
Hi, Dr. Chimzizi. I don't think you've said everything. I think you've summarized the presentation actually. So yeah, the simple answer is yes, you can replace BTQ with delamanid, especially in the situations where there's intolerance by the patient for bedaquiline or the shortage. So there are sometimes where you can't use bedaquiline, but you can use delamanid.
All right, thank you so much, Dr. Chimzizi. There's also another question which came in from Irene Walia asking about whom are we going to prioritize for this predominant-based regimen, considering the current stock is limited. Maybe I'll throw this to Dr. Mputu since you are the advisor to the NTP on DRTB.
Yeah, so it's not about whom we are going to prioritize, because that will indicate that some patients will be disadvantaged. But rather than we'll probably pilot this at a few selected one or two facilities, depending on the number of patients they have. And then after that, when we have more predominant that comes on data, then we can transition to the rest of the country. So the limit here is the fact that the predominant that's available in the to roll out at all facilities. So it's just about maybe one or two facilities that we initially start as we are waiting for more of these drugs. But the training and everything will be, assuming everything is in place. That's how we are going to approach. Over.
Awesome. That sounds very good, actually, and reassuring. So, colleagues, this is going to be implemented in a phased approach. So, if you don't see the predominant in your province in the next 2 months, do not despair. It's being rolled out in a phased approach. Are there any additional questions or comments regarding the presentation? You could
so before I wanted to say something over the patient from Kwimi.
Yes, Dr. Mputu, please go ahead.
So this Kwimi is in Eastern Province, I'm assuming.
Yes, Doc.
Yeah, so I would like you to get in touch with the coordinators or even the provincial. I don't see her on the call. Please get in touch with her so that she can facilitate the transfer, the submission of sputum to SACA. We can run the sputum at the reference lab here and see what we can grow. There's a very similar case in Chingola. I don't know if there's anyone from Chawama from Chingola. They had a similar case, and we ended up finding that the patient has actually INH monoresistance. So, like Peter had said, sometimes it's resistance to other drugs, but the only way you can be sure in your case is if you have culture done to see if it will grow anything. So please get in touch with your coordinators. They know how to get in touch with me and ensure that the sample for the patient has arrived. I'll make a follow-up from here on your behalf. Over.
Okay, Doc, I will do so.
Wonderful. Thank you so much, Dr. Mputu. Thanks, Team Ukwimi, for that scenario. Any other questions on the subject at hand, which is a shorter treatment regimen for drug-resistant TB using the BPaLM regimen? Any questions? So we're just about 5 minutes till we wrap up. Any questions? Okay, so let me just ask Dr. Chanda to also just share a few pointers on this subject before I ask Dr. Mputu to wrap up for us. Dr. Chanda, anything you'd like to share regarding this subject? All right, I'm struggling to get Dr. Chitalu to give us a few comments. So Dr. Mputu, over to you. Please wrap this up for us.
I think
Beginning, before Dr. Mputu.
Dr. Chimzizi, I think I heard your voice. Please go ahead.
I'm saying before Dr. Mputu wraps up, I think it is good to remember that when we roll out, and because definitely there will be training and mentorship where we are going to roll out the shorter regimen, but that what will be critical is to make sure that when the patient complete treatment, they should be still follow-up to make sure that, because this is a new regimen, so we don't have just to throw the patient after completing TB treatment. As per recommendation in the guidelines, we should be able to be also following these patients until we are to make sure that there could be potential relapse, it could be potential the same thing you were talking about, Dr. Singini, about post-TB disability. So there will be follow-up. Suffice to say that when loading up, definitely we're just not saying start, but we should be able to build capacity. Initially, maybe a team of people to train and then continue those people trained to mentor where we are cascading this rollout. I thought I should say this, and it will be very clear when we start loading out. Thank you so much.
Thank you
thanks,
so much, Chimzizi. Dr. Mputu, over to you to wrap up.
Thanks, Dr. Chimzizi, for that. I had a slide on that actually. I don't know how come it didn't save, but thanks for adding that. Just to wrap up, it's a message for me here is that our patients are suffering with the longer drugs exposure to side effects. So we have evidence now that treatment can be shortened, and therefore we should strive to ensure that we give them the shortest possible treatment that is effective, that is safe for the patient. And now we have a lot of options for both the 9-month treatment regimen and for the 6-month treatment regimen that we are rolling out this coming year. So please let's not prefer to give our patients the longer treatment regimen when there are other alternatives that they can take for the shortest period of time. And Dr. Chimzizi is probably be interacting more and more this year as we do mentorship, as we do more regarding the same. So I hope to meet some of you in person this year. Over, David.
Singini.
Dr. Mvanga, please go ahead.
Apologies for me. I think it's I'm interested also in what Moses, the patient coming from Moses. So probably Moses, you can just quickly get in touch with Dr. Mputu. If you can just put your number there in the chat box so that we can just liaise at the end of this meeting. Over and thanks.
All right, thank you so much, Dr. Mvanga. Thank you everyone for your participation in this call. Very interesting stuff coming up. Looking forward to having this change the landscape for TB in Zambia going forward. Now that we have efficacious drugs, better side effect profile, shorter duration of treatment, I think this will help us achieve better treatment success rates. So thank you so much. I'll leave this meeting on for a few seconds for those that are sending numbers to Dr. Mputu, and then we'll close the session. Thank you and bye.